Director Baystate Rehabilitation Care, certified by the American Board of Physical Medicine and Rehabilitation in Physical Medicine and Rehabilitation in Sports Medicine. He is certified by the American Board of Electrodiagnostics. He is also professor at University of Massachusetts Shan Medical School, Baystate, USA. Dr. Martinez-Silvestrini will be delivering the Fairling Memorial Lecture. Over to you, sir.
Thank you. Okay. Can you see the slides? Can you see them?
Yes, sir. We can see you.
Okay, perfect. Yes. So thank you for the invitation. I'm very pleased to be able to talk to you in this morning. Here in Massachusetts is 11 a.m. So I will be going over Can you see that I'm sharing the screen? Okay.
Yes, sir.
So now, can you see my screen or you're using your screen?
We can see you and we can see our screen. The PPT is on our screen.
Oh, okay. Because I can share my screen here. Can you see it? That works? Yep. Can you see them moving?
Yes, sir. Yes, sir.
Okay, I'll do it. Perfect. So thank you again for the invitation. And today we will be discussing low back pain in the 21st century. I have basically today we will discussing the global health burden of low back pain. We'll have a brief discussion of most common types of low back pain and how to differentiate them. Now, I will not be discussing all possible causes of back pain. It's impossible to talk about all the causes of back pain in 40 minutes, so we'll focus on the ones that I see mostly in my office. We'll discuss the current trends of low back pain treatments in the 21st century, and I will share some of the experiences that I had and medical perils that you can use and if you have any patients or you see patients with back pain. I have nothing to disclose. I don't have any economic gains for giving this lecture. Low back pain is defined as pain, muscle tension, or stiffness localized between the last rib and above the inferior gluteal fold. About 70 to 90% of people in developed countries will have at least one episode of back pain, and most of them, about 90%, will improve between 4 to 6 weeks. Chronic back pain affects more than 10% of the population and is defined as back pain that lasts more than 12 weeks. Low back pain remains the second most common reason to seeing a doctor in the United States, being the first one upper respiratory tract infections, and is one of the leading causes of cost and sick days in most countries on the Western Hemisphere. Now, around the world, back pain is the leading cause of years lost due to disability. It has an annual prevalence of 38% and a lifetime prevalence of over 40%. About 223 million of cases of back pain in the world, affecting mostly people between 50 to 54 years old and females more than males. and a 1.3 to 1 ratio. Now, one of the first things that we want to do when we see patients with back pain is try to know how it started. If there's a specific injury that caused this back pain, was this patient, for example, lifting a heavy object, or they just turned in bed the wrong way? Also important to know when the pain started. It wouldn't be the same if I have a patient that has back pain for 2 weeks versus someone that has back pain for 20 years. It is also helpful to know what makes the pain better or worse. For example, we'll discuss in a few slides, there's some back pain that get better when you're sitting and get worse when you're standing up. And most back pain gets better when you lay down. It's also important to know modifying factors. For instance, if I have a patient that has a significant improvement of their back pain using a medication like ibuprofen, I may use ibuprofen in the management of their back pain. So it's important to listen to the patient, and they will give you a lot of information when you do the medical history. Now, I would like to use this model. I modified this model from statements. And what we'll look here would be first, when we are seeing with patients with back pain, we want to know first if there are any extra vertebral causes of back pain. For example, a herpes zoster infection or shingles that may happen in the trunk area that can cause back pain. Kidney stones can also cause back pain. So we want to be sure that there are no causes that are outside the spine that are causing back pain. Now, after we rule out these problems, then we want to look at red flags. And if any of these patients have red flags, we need to refer the patient for urgent imaging or maybe urgent evaluation. These red flags can be divided on progressive neurologic symptoms, malignancy, or infection. So if the patient is having progressive weakness, problems with urinary control, specifically urinary retention, and stool incontinence, that may be something that may require urgent medical evaluation. Now, patients that have history of malignancy, if the patient is losing weight too fast or they're having pain at night, that may be consistent with a malignancy. Now, as I said earlier, most patients with back pain will improve their back pain when they, at nighttime, when they lay down. So if the pain gets worse when you lay down, it's possible that there is a tumor that is congested with blood. The tumor will get bigger, the tumor will start pressing against nerves, will maybe pressing against the bone, and it will increase pain. So that's why patients with tumors may have worsening back pain at nighttime, and most of the other patients get better at night when they rest. Other red flag is infection. Keep in mind patients that have immunosuppression, for example, patients that are taking medications after receiving a transplant, or patients that suffer from HIV, patients that use intravenous drugs, anyone that had a back injection, recent infection or recent bacteremia, urinary tract infection may have a risk of having a spine infection. As well, patients that are having symptoms like fever, chills, or night sweat. Now, for example, this is a patient that I saw in my office. She was admitted in an acute rehab hospital, and she couldn't do rehabilitation because she was having very, very severe back pain. When I saw her, I realized that she actually was finishing chemotherapy for breast cancer. I immediately ordered an MRI of the spine, and unfortunately, this patient has tumor covering her sacrum and the perisacral soft tissue, and most likely part of the calvequina. And so listen to the patient if they're having a history of cancer and if they're having worsening pain. It's very important to think about possibility of something bad on the spine. Now, when we pass the red flags and we know the patient doesn't have anything that require urgent or evaluations, then we will try to define our back pain. Now, acute low back pain is considered back pain that is being attacking the patient for less than 6 weeks. Most of the time, it will get better in 6 weeks or less. Now, very important to keep in mind that unfortunately, the most common risk factor to have back pain in the future is a history of back pain. So if a patient have acute back pain, you can virtually guarantee that they will have back pain in the future, for which it's important for this patient to be evaluated and try to determine if their back pain is, you can make a specific back pain diagnosis, or they have the diagnosis we call non-specific low back pain. Now, these two different diagnoses can be defined and can receive treatment. And for specific sense that I like to call in with spine, this would get worse when the patient is bending over to pick something from the floor or even sitting down. Commonly, people use the term sciatica to describe radicular pain. We discourage the use of this term sciatica because it implies that the sciatic nerve is injured. Most of the time, that is not the case. I'll tell you, I've been working in Massachusetts for 20 years. And if I'm not mistaken, I think I've seen 3 patients. From all the patients that I see with back pain, only 3 patients with sciatic neuropathy. So it's a relatively uncommon cause of back pain, for which we discourage the use of sciatica as a term and prefer to use radicular pain or radiculitis. Now, radicular pain usually described as pain that shoots down the leg, maybe burning sensation. Patient may also have pain and numbness. Now, if the patient has weakness in association with this radicular pain, you may be thinking that they may have a radiculopathy. Most of the time may be related to a compression on the foramina or maybe a disc herniation. Another possible cause, if the patient have a normal neurologic examination, would be either sacroiliac joint dysfunction, with the patient will have pain in this area on that connects the sacrum to the iliac crest, or may have a piriformis strain or piriformis syndrome, in which they will have pain in the area of the gluteal fold or buttock. As part of these diagnoses that have radicular pain with weakness, common cause would be disc herniation. Here you can see illustration in which you see the hard annulus fibrosis with a soft nucleus pulposus that herniates and compresses the nerve. Here you can see, actually, this is one of my patients. So this cartoon I found on the internet, this one actually is one of my patients. This patient had a herniation and is compressing this nerve. You can see this nerve is very big and swollen compared to this nerve that is smaller. So this patient is having a radiculopathy. In this side, basically the convention we use is that this side is the right and this is the left, so we'll have a right-sided radiculopathy. On the lateral view, this is an axial view, so the front will be here, this will be the back, this is right, this is left. In the sagittal view, the front will be here, this is the back. You can see a normal disc. It has a hard annulus fibrosis with a soft, bright nucleus pulposus. Here on this disc, here you can see that this is degenerated. It's not white in the center. And you can see how that this is herniating posteriorly, compressing this nerve root here. Another cause of radicular pain, in these cases when the patients are standing up or bending their spine backwards, what we call spine extension, would be spinal stenosis. Again, the illustration of the annulus fibrosus, nucleus pulposus, central canal with the spinal cord. Now, patient may have herniations in this direction, arthritis with spurs or osteophytes going into the canal, and that can result in compression of the spinal cord. Now, most patients with spinal stenosis will not have back pain, even though this illustration shows that. Most of these patients with spinal stenosis will have pain with standing, and they will have pain in their buttock and the posterior thighs. Other patients may have just back pain when they're standing up, or just back pain when they're bent backwards, and that may be related to what we call facet hypertrophy, facet osteoarthritis, or what is also known as facetogenic low back pain. Here you can see the lumbar facet joint, and this joint is degenerated, causing pain. Like some people develop arthritis in the knees or their hips, some people develop arthritis in their spine. Now, this patient will have more pain with extension, localized or general back pain, depending on how many of these joints may be affected. They may have arthritis in this joint, and this joint, so we'll have a little more general pain compared to someone that has just localized back pain. They will not have pain down on the legs, and this may be related to remote trauma or maybe just degenerative changes related to age. Now, the last syndrome I will be discussing will be mechanical low back pain. This is also described as non-specific back pain because the pain may be related to muscles, may be related to the joint, may be related to the ligament, or may be related to more of one of these. So it's very difficult to pinpoint exactly what so the pain for which will be describing specific back pain, the term mechanical low back pain. Patient will have pain with movements, usually will have stiffness that lasts less than an hour. Any patient that has stiffness longer than an hour, we may need to think of a possible rheumatologic condition. Now, they will have diffuse tenderness to palpation, won't be localized to one point. They will have pain in the joints, in the muscles. They will have pain usually limited in both, or they will have pain with flexion and extension of the spine. In rare instances, they may only have pain with flexion. And they will have a normal neurologic exam with normal leg reflexes, normal strength, and normal sensory examination. Now, once we have our diagnosis, some diagnoses may need x-rays. So the first step before ordering an x-ray or ordering an MRI is try to determine what will I do with these results. So it will not change my treatment. Most likely it's not necessary to get that test done. Now, I recommend x-rays in patients that have history of trauma. Any patient that has back pain that is chronic, so over 12 weeks or 3 months, and they never had an x-ray, may be a good idea for you to get an image. Also, patients that have spine extension, that you're suspecting they have lumbar facet, spine pain with extension, they may suspect they have the lumbar facet disease. You would like to do x-rays with an oblique view that will emphasize that facet joint. And lastly, if you suspect the patient may have a rheumatologic condition affecting their spine, you may like to obtain x-rays. Now, MRIs, the main indication for MRI is if you're planning surgery or injection, if the patient has high risk of malignancy, or one of those red flags that we discussed, infection, progressive neurologic deficits. We don't do MRIs just to see where is the problem, or what is causing the pain. I can easily know that doing a good physical examination. Now, just for illustrating why we don't do MRIs just to make a diagnosis, they did this study in 1990, and they took 67 patients without back pain, asymptomatic, and 1/3 of them had a positive MRI. And if you look at the age, if any patient older than 60, more than half, 57%, had positive findings on MRI, even though they didn't have back pain. Now, it gets better, because I don't know how, but they were able to find 50 of those 67 patients 10 years later, and they repeated their MRI. And they found the following. The MRI was not predictive of developing back pain or duration of back pain. In other words, the MRI won't tell you if the patient has back pain. It won't tell you if the patient will develop back pain, and won't tell you how long the back pain will last. So the MRI might help you a lot of information. Very important to start with the physical examination. Now, this is a patient that came to see me to my office. She came with these MRIs. She had an MRI done in 2013. We showed this herniation. You can see how this MRI looked like the other MRI I showed you earlier, so that this like to herniate a little bit what we call paramedian, a little bit to this side here. And you can see that fragment of this that is not touching a nerve, but is there sitting on the central canal. Now, the patient had another MRI 1 year later, 2014, and guess what? The MRI was reabsorbed, no surgery, no treatments. Now, that happens spontaneously. Why is that? So your body, like you can heal any type of injury, like a paper cut, for example, in your finger, you heal this. So this herniation is not a life sentence of back pain. Now, when we look at this patient specific detail, if it's not herniation was causing the pain, what is causing the pain? If you look here, this is the paraspinal muscle. All this white stuff here is fat. So her muscle is atrophied. And that is the reason why she had back pain. She had a lot of muscular atrophy in her back. You can see it here too. And that was the reason for her back pain. It was not the herniation, it was really the muscular atrophy in her spine. Now from here, what do we do for these patients? We will manage them with a multimodal assessment and approach. Now, very important to understand that the treatment of back pain is moving away from spine injections, prescription of opioids, and just passive therapy methods like using massage, heating pad, and electrostimulation. In the past, some patients won't go to the therapist and they just want massage and heating pad. They don't want to do exercise. We don't do that anymore. Now, I am not saying that we don't do spine operations or we don't do spine injections. We will not just do spine operation because we can. We only do if the patient needs it. We will not do injections and have the patient come back in 3 months to get another injection, and have the patient come back again in 3 months for another injection, and just do injections without doing anything else. No. We do injections as part of a comprehensive plan that includes education, exercises, and behavioral psychotherapy. Now, our treatment protocol is as follows. We will follow these 6 steps. Pain control, number 1. Restoration of range of motion. Improvement strength and endurance. Coordination retraining and cardiovascular recondition.
Is talking about.
Now, once we have completed the rehabilitation programs, the patient will continue a maintenance exercise program at home. Now, the failed application is that we are not doing a good job trying to control the patient's pain before we refer them to physical therapy. Where the patient failed mostly is that they don't keep doing their exercises at home until they are symptom-free. And that is the clue for, basically the key for success is pain control, restore range of motion, restore strength, restore coordination, restore cardiovascular fitness, and maintain an exercise program. Now with this protocol, and this is a protocol that was created in 2011, and I'm bringing it up because it's so good. After a year of this treatment, not only the patient's back pain improves, but their overall increase in their health, so their overall health improved, and health costs went down. So we had healthcare savings. So this treatment not only improved the patient's back pain, improved their general health, and decreased medical costs. Now, when do we refer patients to see a physical therapist? I will send any patient that have an acute low back pain because there's a lot of treatments that our skilled physical therapists can do to decrease acute back pain. Now, chronic back pain is more complex and there's a lot of different type of pain generators that occur after you have back pain for over 12 weeks. For which I personally recommend that any patient that having chronic back pain, they should have a pain of 7/10 or lower at worst. So their worst pain should be 7/10 or less before we refer them to physical therapy. If not, we need to manage pain. How we do that? We can do medications. We will limit use of opioids. I personally don't recommend opioids unless the patient have spine space occupying lesion, spine tumor, or a fracture. Can be used in the future, but the first line would not be opioids. We can also do injections, but injection is not the treatment. Injection is a tool we use to decrease pain so the patient can participate in physical therapy. Now, what kind of medications can we use for pain if we're not using opioids? You can use non-steroidal anti-inflammatories and acetaminophen, of course, not contraindicated. In patients that have liver disease, they should not be using acetaminophen or non-steroidal anti-inflammatories or NSAIDs. Now, if the patient has kidney disease, history of cardiovascular disease, heart attacks, problems with their bleeding in their stomach, GI bleed, then you cannot use non-steroidal anti-inflammatories. You can use anticonvulsants or duloxetine if you know that the patient has neuropathic pain, that radicular pain with burning, tingling, numbness. You can also use muscle relaxers if the patient have a muscular injury, muscle strain, or increased muscle tension. Now, we need to keep in mind that muscle relaxers, antidepressants, or anticonvulsants can cause sedation. So in older patients that have high risk of falls, we need to be very careful. Now, for injections, in the United States in 2018, we did 5.6 million injections. That's a lot of injections. Now, they discovered in this study done in 2022 by Cohen that these injections have variable level of effectiveness. They did epidurals, facets, and SI joints, variable levels of effectiveness. Why was that? Because they were not selecting the patients correctly.
I think maybe
I personally recommend the patients are selected as following. Patient has tried and failed physical therapy. The patient has tried and failed medication. And then we need to have a proper diagnosis. If you have a proper diagnosis and the patient has failed conservative management, and your goal of the injection is decrease pain so they can participate in physical therapy, I really think that we can improve the outcomes to injections. Now, other risk factors. of injector failure include obesity, smoking, patients that are on disability or workers' compensation, and patients that have uncontrolled psychiatric conditions, specifically depression. So it's important for us to look at the patient as a whole and don't focus on the back pain only. If the patient has other comorbidities like poorly controlled depression, they're obese, and they're smoking, it's important to treat those as well so we have better success on their care. Now, when to send a patient to see a surgeon? If the patient has progressive neurologic deficits, and they're getting weaker every time that they're seen by the doctor, and they have weakness of 3/5, and this scale, basically 3/5, is that they have difficulty, they can move the leg against gravity, but they're having difficulty lifting the leg against gravity. That may be something that, if not treated quickly with surgery, they actually may remain very weak. Or patients that are having severe radicular pain, pain shooting down to the leg that does not improve to treatment, including medication and injections, they may need to be seen by a neurosurgeon. Now, let's keep in mind that there is no surgery for non-specific or mechanical back pain. There is no surgery for facetogenic low back pain or facet or joint arthritis. There at this moment no surgery for this diagnosis. So these diagnoses are treated with conservative management or rehabilitation. Now, when you send patients to a specialist like me, physical medicine and rehabilitation, I don't focus on the pain, I focus on the patient function. We treat the pain, but our goal is restore their function. What do? We collaborate with our rehab colleagues in physical therapy and other rehabilitation services. We can prescribe to the patient braces, canes, walkers, or other assistive devices that they may need. We also do medications and injections to control the pain so they are successful with their rehabilitation. Now, in conclusion, low back pain is still a significant healthcare burden in the 21st century, and early diagnosis, adequate diagnosis, and early and adequate treatment are essential to decrease this future health crisis. These are my references. I want to thank you again for this opportunity. I will open for any questions that you may have. I forgot to mention that this is my tagline for Twitter and LinkedIn. You can join me there. And I know that our time is limited, so if you have any questions that you want to continue follow up, feel free to send me a tweet. Feel free to join me on LinkedIn and we can discuss. This is my hospital, Baystate Medical Center, and we are in Western Massachusetts, in Springfield, in the United States. And thank you for this opportunity of sharing my knowledge with you.
Thank you, sir.
Presented, so much of informations, and it is a really eye-opener, for a lot of us. And we are very much, thankful for your wonderful session. Our students, our delegates may have few questions. So should we take, that questions for you?
Yeah, I'm open to any questions you may have.
Right. So I'll be asking, that student volunteers, please go to the respective students and take the questions. We are having just 2 to 3 minutes time. We are running late, so please hurry up and clear your doubts. And already, if you have any questions, please, Dr. Martin.
So my question is, what do you think the leading cause of back pain in 21st century? Is it occupation related? And can cause permanent disability?
Yeah, I'm sorry. Very well.
leading cause of back pain in 21st century? Is it occupation related? And can those cause permanent disability?
Occupation related, or they are other causes of back pain, and how can we treat it? So there is no one reason for back pain. For example, some people have family that they have bad backs and they develop back arthritis, and that may be related to their genetics. Some patients may be related to occupational. For example, if they're doing a lot of heavy construction work. Now, it's important that any person, for example, if you have a patient that is a construction worker, or they take care of a farm and they actually take care of, or they do any type of physical activity, that they train their back like they are an athlete. But their goal is not necessarily to compete on the Olympics. Their goal is to do their work without injuring themselves. So occupational health is a field in which the specialists focus in actually keeping basically employees healthy and safe. But definitely there are multiple causes of back pain. I'll tell you, I think I have more patients injuring themselves picking a pen from the floor than picking heavy objects. Because if your back is weak, we're spending a lot of time sitting. All of us, we're sitting here. We're spending so much time sitting, our back gets very weak. Like that patient, that atrophy in the muscles. So it's important for us to take our time and focus in our spine and just rehabilitate ourselves.
Right, sir. Thank you, sir.
Radiculopathy is mechanical low back pain. So I just want to know, like, what is the significance of myofascias in case if a patient is having back pain due to spinal stenosis? Like, the myofascias plays a very important role while we are managing patients with low back pain due to spinal stenosis or radiculopathies.
So yes, in patients with spinal stenosis and radiculopathy?
Yes, sir, exactly.
Okay, so now we need to look at the patient as a whole. Even if I have a patient with spinal stenosis, their back pain may not be coming from the spinal stenosis. And that's why the MRIs kind of predict if you have back pain or not. Now we need to look at the patient as a whole. For example, common things that I see, the leg muscles may be very, very tight, hamstring shortening, weak core muscles. One thing I see very commonly is also hip flexors are very tight. So definitely it's important to look at that, those myofascial structures, the muscle, the fascia, the ligaments, the disc. We didn't discuss discogenic back pain, we didn't discuss compression fractures, we didn't discuss scoliosis. So there's a lot of other type of levels, but I'm glad that you brought this up. Yes, definitely the muscle, the fascia, the ligaments are vital and may be pain generators in these patients.
Okay, sir. Thank you.
For this your session.
Thank you.
And we'll be connecting with you maybe many a time, and after this session there may be few questions more. So I'll be collecting all these questions and I'll be sending to you, right? And from
Thank you.
all the members of the organizing committee of this international conference, I'd like to thank you for your wonderful session once again. Thank you very much. Thank you.
Thank you. Enjoy your meeting.